Hi, everyone. Welcome. Thank you for tuning in. My name is Audrey Stewart, and on behalf of Harvard Bookstore, I am so excited to welcome you to tonight's event with Jim Downs discussing his new book, Maladies of Empire, How Colonialism, Slavery, and War Transformed Medicine. And he is joined tonight in conversation by Sven Beckert. Through good times and bad, Harvard Bookstore will continue to bring our authors and their work to our virtual community. Our fall season is ramping up, and boy, do we have a lineup for you. Make sure to check out our event schedule at harvard.com/events, where you can also sign up for our email newsletter and browse our shelves from home. This evening's discussion will conclude with some time for your questions. If you have a question at any time during the talk, go to the Q&A button on your screen and we'll get through as many as time allows. If you would like to purchase a copy of Maladies of Empire, there will be a link in the chat where you can purchase. All sales through this link support Harvard Bookstore, so thank you. There will also be a link for donation in the chat if you would like to give additional support to Harvard Bookstore. Without your continued support and patronage, this virtual author series wouldn't be possible. Thank you so much for tuning in support of our authors, our incredible booksellers, and our landmark independent bookstore. We sincerely appreciate your support, especially now. And as you may have experienced in virtual gatherings, technical issues may arise. If they do, we'll do our best to resolve them as quickly as we can. Thank you in advance for your patience and understanding. Now, I am so pleased to introduce tonight's speakers. Jim Downs is Humanities Professor of Civil War Era Studies and History at Gettysburg College. He is the author of Sick from Freedom, African American Sickness and Suffering During the Civil War and Reconstruction, and Stand By Me, The Forgotten History of Gay Liberation. He has edited 6 anthologies, including Beyond Freedom, Disrupting the History of Emancipation, co-edited with David Blight. His essays have been widely published, including in The Atlantic, The New Yorker, The Washington Post, The New York Times, Vice, Slate, and more. He's a busy man. He is joined in conversation by Sven Beckert. Sven is a professor of history at Harvard University. He is co-chair of the program on the study of capitalism at Harvard, co-chair of the Weatherhead Initiative on Global History, and co-editor of a series of books on America in the world. Sven's work has been supported by the Guggenheim Foundation, the American Council of Learned Societies, the Humboldt Foundation, and the New York Public Library Center for Scholars and Writers, among others. Tonight, they're discussing Maladies of Empire. The history of medicine often highlights the ready-made heroes, such as Jon Snow or Florence Nightingale. Jim shows that the studies of infectious disease depend critically on the unrecognized contributions of non-consenting subjects, conscripted soldiers, enslaved people, and the subjects of empire. Plantations, slave ships, and battlefields were the laboratories in which physicians came to the understanding of how diseases spread. Maladies of Empire takes a critical look at the medical history that is ignored. Harriet Washington said about it, Maladies of Empire provides an illuminating, painstaking, yet engaging interrogation of the original records and sources, filling critical gaps in the development of epidemiology, indispensable and compelling. And on that note of praise, I'll turn things over to our speakers. Jim, Sven, thank you so much for being here tonight. The virtual stage is yours.
Thanks for having us, Audrey.
Thank you so much, Audrey. It is great to be here. Jim, it is great to be here with you. I was privileged to be able to read the book before it was published. I think I read it this spring, and I was very much impressed by it. And I wrote a little blurb in which I called the book brilliant, a timely book, a most original global history that is required reading for historians, medical researchers, and really anyone interested in the origins of modern medicine. And of course, it is also a book that is strangely timely because just at the moment when you finished the book and when it went through the publishing process, the COVID epidemic hit, and we were all talking about public health and disease and other such things. So it is a most impressive book. It is very tightly argued. It is beautifully written. And it's relatively short. It's a relatively quick read. I think it comes in at about 200 pages, but the main argument is embedded within a number of deeply researched stories that you uncover from the archives basically about how the violent control of populations in the 18th and 19th century, how that made possible certain observations that then led to certain kinds of advances in medicine. And Jim, the book raises so many questions, but I first wanted to start out by just asking you if you could just summarize for us what your main arguments is. What do you hope the reader is going to take away from the book?
Okay. Well, first, Sven, thank you so much for doing this. Thank you so much, Audrey. One of the main points that I want readers to sort of take away from this moment is just that medicine, as we know, goes through a major transition in the mid-18th to the mid-19th century. So most historians of medicine, most medical history books would sort of identify 1750 to 1850 as this sort of critical turning point in terms of therapeutics, in terms of understanding of the spread of disease. This is a moment when people begin to realize that epidemic disease is not necessarily simply the result of a supernatural force of God or something else, but instead they begin to sort of see they begin to sort of look towards the environment. They begin to look at social factors as the cause of it. And so in general, the history of medicine is typically just this province over here where we just study doctors and healing and various ideas. I came at the history of medicine as a historian of slavery, as a historian of Reconstruction, as a historian of emancipation. And I noticed that between 1750 and 1850, you have major social transformations. Namely, you have the rise of the transatlantic slave trade, the expansion of empire, and two modern wars, the Crimean War and the American Civil War. And so ultimately, these social transformations that have often been sort of siloed over here as social history actually transformed medical practice and gave way to the origin of epidemiology. Now, at first, when I was doing the research and I'm going through the sources, I'm thinking there's definitely a link to epidemiology, which in its cleanest, sort of shortest, most brief definition is just simply the study of infectious disease across populations, how to control that epidemic disease, and also how to prevent it. And so I saw there was a link, but when I got further into the research, I realized that slavery, colonialism, and war provided the setting that actually led to the development of epidemiology. That the traditional story of epidemiology often begins in England in the 1850s when a guy by the name of John Snow, not to be confused with Jon Snow from Game of Thrones, goes into a British neighborhood to study the spread of cholera. When he gets there, he interviews people, he tries to track it, he's trying to understand why it can be in one house, but skip over another, and then only infect two people in the next house. He engages in a really intense investigative method. And that method ultimately leads to what many historians call the development of epidemiology. But John Snow had gained experience, evidence, and insight from a cohort of physicians before 1848 and 1850 that had been traveling on slave ships throughout the empire during war and had been developing epidemiological methods.
Right. Well, so the three sites of your investigation are slave ships, war, and kind of colonial governance.
Right.
What do they have in common? I mean, how do you see them all contributing to this project?
Right. So each of those environments does something very interesting that connects to our understanding of the pandemic today. They crowd people together, and they create new sort of built environments, controlled environments that crowd people together in unprecedented ways. So this is before the rise of industrialization. This is before the rise of tenements in the early 20th century that are sort of a hallmark of sort of big cities. At this particular time, you only see crowding together in some hospitals and in prisons. And because most people at that particular time didn't care about prison populations, they didn't care about people who were in hospitals largely because they were dispossessed, they were people who didn't have families. Ultimately, the studies, no one really cared about disease outbreaks in those environments. When disease outbreaks happened in crowded conditions on slave ships, which were actually much worse than prisons or hospitals, they started to take notice and they started to worry. When disease outbreaks start to happen within as part of colonial endeavors, they worried. And then when battlefields became sites of disease, especially during the Civil War and the Crimean War, when more soldiers in both the Crimean War and the Civil War died of disease than from battle, that was a problem.
And so can you tell us a little bit how doctors discovered these connections?
So it's a really interesting, it's more, there's two things here. One is that as a historian, I've sort of placed them all together. So some of this is just my interpretation. And I wondered and worried, well, wait, is this just the way that I'm reading the records? But ultimately at the time, they understood these places interchangeably. So when I was looking at Confederate medical records, and I'm reading doctors in the South who are studying epidemic outbreaks among prisoners of war, their evidence is what's happening in Italy, what's happening in Germany in terms of inoculation, in terms of vaccination campaigns, in terms of epidemic disease. They're actually using and imagining these places as well. At the end of chapter 2, I end on this one guy, Gavin Milroy. And Gavin Milroy is this doctor that sort of predates John Snow, is actually much more influential in the 19th century than Snow ever was. And he has a line where he actually says, there are ships, slave ships, hospitals, plantations, battlefields. He actually names these places. In their imagination, what's happening is they see these places as sites to gather medical information, in large part because the practice is the same. Doctors in the metropole in London are deployed on slave ships. They're deployed on colonial plantations, and they're deployed during war. So the same process happens. Then what's really interesting is they start all filling out similar records. The bureaucracy of the military bureaucracy that governs the military and colonial bureaucracy that governs slave ships, colonial expansion and war is identical. So these doctors go out to these places, they report this material so that even if they're like someone like Milroy might not have been on a slave ship, he's following the same formula, the same forms that other doctors are. And when he returns to England by the 1850s, they say, we need to form the London Epidemiological Society. And there he's rubbing shoulders with doctors who have been in Brazil, doctors who have been in the Ottoman Empire, doctors who have been in Egypt, in the Caribbean, and they're learning from doctors in the US and other parts of Europe. So that's what sort of creates this sort of intellectual community of these physicians.
How come we forgot so much of that history? How can we tell a different narrative about the history?
Yeah, so I think it's interesting in a lot of ways. I mean, I think part of it is, there's two answers to that. So the first answer is that we have, I sort of think about this a lot in terms of, and I try to make this analogy, I don't know if I'm going to be able to make it successfully or not. It's very similar to the ways in which literature, there's like a Western canon, and the way in which certain thinkers are reified as being this sort of iconic speakers of literature, and then others are on the margins. And so what happens is John Snow is sort of remembered by his students. He's resurrected by his students. He's canonized by his students. And these other doctors are sort of forgotten. Compounding that, the notion of scientific revolution is always happening in the West, is always happening, people think, in these major urban centers like London, Paris, and New York. So the idea is often that Malta, for example, or the Jamaica, they're on the margins, they don't matter, just the way that we would imagine writers from those places as on the margins. But in actuality, the margin is actually, as they say in post-colonial theory, the center. And in this particular case, London is on the margins. So part of it is just reframing our historiographical orientation and following the records to actually see who was producing knowledge about epidemics, and it was on the margins. The second is actually related to the work that you've done with slavery and capitalism, which is to say, when we thought about slavery in the past, we thought about it in all the ways that matter: the exploitation of enslaved people, the profits of the Southern economy. We didn't necessarily see it as something that contributed to the larger system of capitalism. Scholars out of the Black radical tradition did that, and then you and Seth Rockman and other people have done that. And so I think there's a movement among scholars to say, hey, these institutions actually had effects beyond the plot of what we often think. And so slavery's effect is also in the creation and advancement of science, just like it was in the advancement of capitalism.
Right. That's a really terrific argument. And I like the idea that in many ways the margins, what was at the margins was really at the center of historical development. But I'm just thinking, okay, with you mentioned capitalism. So capitalism, among other things, it does produce profits, it produces money. And money is kind of, once there's money, the origins of that money can be hidden. They are not necessarily visible within the money itself. But with medical research, it seems to me slightly different because, there are these records that you mentioned. They produce a lot of paper that tracks certain diseases in certain kinds of environments.
Right.
And it's the basis of that empirical evidence that they develop certain ideas about the spread of diseases.
Right. So
how do they hide the origins of that evidence? I mean, how does that disappear? I understand that certain doctors become less prominent and they get forgotten. I can see that. But how does the evidence in some ways get forgotten?
It doesn't disappear, it gets reframed. So here's an example. Thomas Trotter is deployed to go on a slave ship. He thinks he's going onto a slave ship to monitor the health and the well-being of the crew. He invariably realizes that so many enslaved people are dying at the bottom of the ship. They're dying mostly of scurvy. And so he read about scurvy. He knew a little bit about scurvy. We don't know how much he treated scurvy, but he starts somehow communicating with the enslaved people, either through a translator or otherwise, and learns about the symptoms of scurvy, learns how the tongue sort of goes lopsided in someone's mouth, learns about the pain, the way the jaws lock. He learns all about it. He then learns that once he arrives in Jamaica, that if the enslaved people eat citrus fruit, that it'll cure scurvy. Now, according to his textbook definition, he knew that citrus fruit could be effective in sort of stopping scurvy, but he watches that they actually can't just eat it. They must directly suck the juices from the fruit. When he goes back, he reports this to his advisor, and his advisor's like, yeah, okay, maybe, all right, that's all right. And he kind of dismisses him. And then he writes the report, and he says, based on a multitude of cases, I have found that if you suck directly from the juices of the fruit, it cures scurvy. Slavery gets erased from the presentation of the fact. The multitude of cases are actually enslaved people. And so slavery gets scrubbed clean from the record. So if you read only the treatise, and this is what happens in medical history, you're going to read the final document. And this is the document. His document is widely published throughout Europe. It's republished in German. It's republished in the United States. And it becomes the major document. But if you read the document in isolation, multitude of cases, well, it could have been from some of the sailors, but it's mostly from enslaved people. So slavery gets wiped off. Similar, Stephen Hales, a major chemist of the 18th century, mostly recognized, and this is really important in light of COVID, for the creation of ventilators along ships. He writes many different treatises. I don't even know, what's the plural for treatise? Treatise, I don't know. He writes many. By the fourth one, it's the most polished version. And he says that the ventilators are incredibly effective at the bottoms of ships. They lead to the circulation of air. The second one that had all of the evidence in it were actually slave ships. And he takes the documents from captains of slave ships who quote verbatim that the enslaved people described the relief they felt when fresh air was circulating at the bottom of the ship. Those people then become the endorsement that the ventilator works. If you only read the final version of the ventilator, you have no idea that it's slave ships, and you have no idea that slavery was there. It was only, and I literally, like, it blew my mind, actually, because it's, and my manuscript editor at Harvard was just absolutely brilliant, because there was a point where my head was just so, I couldn't, it was all tangled in my head. Like I could look at the second treatise, but then the third treatise and the fourth and the first, and I couldn't figure it out because they reproduce versions of the same one in the later ones. But the manuscript editor, Louise Robbins, a brilliant manuscript person, I have to always give her props, helped me really clarify it and really chronologically organize it. And once you do, and you see this at the very end of chapter 1, slavery is scrubbed clean from the record. And then the third thing is, and this is just me just guessing, and this doesn't get in, this is in there, but not so much. What do people in the 18th century mean by ships? We know they sometimes say slave ships, other times they say ships and they mean slave ships, but they don't have to say it. Just like we would say public housing, and we know public housing is for poor, often brown and black people, but that just gets, that's a term that in the 20th century, public housing. So the term ships also scrubs clean the references of slavery as well.
Okay, but that means that the violent origins of these medical findings were erased almost at the moment of origin, at the right.
100%. And that's why, you know, as a historian, my job is to organize the past. My job is to go in there and try to lay that out and to show that this process happened. Now, the question is, was it purposeful, or was it just a matter of rhetorical practice? And it's unclear, but then that's why I go back to post-colonialism, and you actually read Gottfried Spivak and you read these different writers, and you can sort of see that these elisions are often purposeful. I mean, I talk about this in the introduction to the book when, you know, what is the guiding methodological practice I have here? And it's Black feminist criticism of the 70s and 80s, which is to be mindful of how these erasures and silences are happening. That these are not, we can say there's an erasure and a silence in Shakespeare, you know, the Black figure in Shakespeare, the erasure and silence in Faulkner. What happens when you have the erasure and the silence in science writing? So that critical practice of reading that came from Black feminists of the 70s and 80s really guided how I looked at these records and tried to sort of say that the very origin there is an erasure.
No, and you do a beautiful, beautiful job at that. Maybe it's a little early, but how is the medical community responding to that, or how should they be responding?
Right, how should they be responding? I would say if Twitter's any sort of metric, I think they're happy to get this. I mean, I think that they've been, you know, supportive. A lot of people in public health, a lot of people who are in epidemiology are sort of wanting new origin stories, are understanding the fact that there's implicit racism within the medical practice and within public health, and they're looking for new origin stories. There's a lot of work. I think there was a review of my book in the Los Angeles Review of Books, where the reviewer talked about a recent controversy around JAMA, which is like the Journal of the American Medical Association. And recently in the spring, they were basically saying like, well, racism doesn't exist in medical practice. And the reviewer pointed out the ways in which my book sort of, you know, questions that. And so, you know, that's part of, you know, that's part of the response. I think for me, you know, we'll see. I mean, there's a hunger, you know, right now among public health to understand what gets called, you know, racial disparity or inequities, and how that actually sort of developed. And I think my book is an effort to sort of think about the broader context of how epidemiology actually grew out of the tools used for colonialism and slavery. I mean, surveillance, data management, all of the tools of slavery are actually the tools of epidemiology. I mean, that kind of like blew my mind as I was finishing the book. I mean, I wasn't, you're working on this, you're thinking about all of these different ideas. And I was like, I don't know if I can really make that claim, but once I got through the evidence, it's all very similar.
Right. Well, what do you consider your most surprising finding?
I would say it goes back to the Stephen Hales example in chapter 1 and this whole idea around oxygen in the slave ships. So historians have noted that so many enslaved Africans died in the brutal transport from Africa to the New World from all kinds of infectious disease and so forth. What we didn't know is that decades later, in the early part of the 19th century, down into the end of the 19th century, the findings from that these doctors sort of generated were actually used to substantiate medical theory. So the book kicks off with an example of a doctor from 1832. He's trying to understand how long the body can exist without eating food. And he just grabs evidence from the international slave trade. Like it's just this basic sort of rhetorical reflex, because this has been in sort of, it so dominates the medical records. And what I found was in Europe in the 18th century, in the 1750s, is the creation of the field of chemistry. And there's a debate among chemists about the creation of oxygen. So people have been studying air since Aristotle. But what they started to study in the 1750s with chemistry was this idea of, wait a minute, the air changes its quality. And they could see how the air was changing its quality in the laboratory, but they didn't know what the effects were on the human body and how it happened with humans. All of a sudden, Trotter provides evidence of the enslaved Africans crowded together at the bottom of the ships and proves that the air changes a quality. There's also a famous example in a jail cell, which I talk about in the book in India, the same thing that happens. What blew my mind was that at the end of the 19th century, when they're trying to trace the origins of oxygen and the supply of air, they're using the slave trade to prove oxygen was a real chemical element. And so slavery helps to prove the validity of oxygen. And so this is something, I mean, that many people haven't thought about. We think about the history of slavery with the 1619 Project and other things. Well, it's important to know for appreciation. No, it's not just about appreciation or rethinking the chronology of the United States. It's thinking about the fact that our advancements in science, our knowledge of medicine can be traced to the international slave trade. And so that was one of the big findings in the book.
Right. I mean, so many people, and so long people have believed that slavery is a kind of pre-modern institution that was done away with by modernity. But in some ways, you seem to be arguing that modernity itself is partly created through slavery.
Right. And also through the bureaucracy that slavery creates. I mean, so that there is this way that modernity produces a kind of bureaucracy that can capture slavery in a surprising place. And so that, there's a lot of work right now being done on the problem of the archive, all of which I support politically, ideologically, intellectually, because I think certain questions are silenced and they are corrupted by the archive. But there are also ways in which we have to shift our scholarly focus to other sites where the archive is completely sort of active and talkative in terms of just, giving lots of material. And the military archives and the medical archives are replete with evidence of slavery. And it's through the sort of modernity of bureaucracy that has captured these voices and these experiences.
It's probably also true that most historians of slavery have not in particular looked into these places.
Right. I mean, so there's right. And so there's that. And part of it, I mean, this is why I think it's cool that you got to interview me and why one of the great things that Sven did was that when I got the Mellon Fellowship to go back to grad school after I earned my PhD in medical anthro, you invited me to become a visiting fellow in global history. One of the things is that I knew the archives in the South. Like I knew the Mississippi archives, I knew the federal government archives. But I thought, wait, I'm an Americanist. Like, can I go into the British archives? Can I go into the Spanish archives? And working under your tutelage at Harvard gave me the chutzpah to actually do the work to go into global archives. And so that's where the story is. I think like early Americanists in the US are much more, positioned to go into European archives, but 19th century historians, not so much. So I would really credit you for that, because I really kind of felt like I could do that. And
but tell us a little bit more about that. I mean, I'm really curious about that, because we have had all these conversations on global history. So how does a global history perspective, I mean, you say it impacted you, the way how you researched the story, but how did it impact how you analyzed the story, how you told
it shaped how I did the research, because I would follow the records. I would follow the records from one place to, it shaped my methodology. That is to say, when I started this project and I realized that I had to go to London, I went to London. I didn't say, oh, wait, I'm a 19th century US historian, I don't go to London. I went to London. And when I went to London and the records were coming up all about Jamaica, I read the records in Jamaica. And when I was at the Welcome and I was at the British Archives in Kew, and then all of a sudden the records led me to the British Library where everything was about India, I went to India. So it was a methodological movement. Now, part of this with global history is that sometimes global history becomes synonymous with every little piece of the planet. And, you can't do all of that. So but I was curious. So I went to, this is not in the book, but I went to Spain. I went to Sevilla. I looked at those archives because as someone who was saying, all right, I'm going to do a global history, I need to make sure that there's nothing in these records that challenges or undermines what I'm doing. And I actually found a very similar process about how physicians were being deployed to Colombia, to Cuba, and Cuba then was on the margins. Everything was about the Philippines, by the way. I mean, this is from the Spanish archives, from what I saw, it was in the Philippines and it was in Colombia, and very similar practices unfolded. Now, what was interesting for me as a historian was that I ultimately didn't put that as part of the story, only because I wanted to center the Epidemiological Society in London as a major factor, and nothing in the Spanish story seemed to suggest that there was a larger narrative that changed this. And then I even looked into Eastern Europe. Like the cholera pandemic of 1866 was all over the world. So I went to Budapest, I went to the Czech Republic, I looked at those state records as well, trying to get a sense of what happened. And similarly, the same idea of using case studies to guide through work. And then I actually went to Malta, where I could see the quarantine facilities that were used. So I felt confident in calling it a global history because I hit a number of the archives. And then the French records are in the secondary literature. And I have a lot in the first chapter about the Parisian clinic. So I kind of felt anxious at a certain point, like, did I hit everything enough to be global? But ultimately, I felt like I covered enough.
No, you do that beautifully. And it's more, the book has a very strong thesis and a very strong argument. So sometimes global histories can also drown out the argument because there's so many things to be told about so many different places all around the world. But I think you do a terrific job foregrounding the major argument that you can understand. I wanted to ask you one more question, and then I think we should open it up to the audience, or maybe two more questions. One is about racial ideology. I mean, what role does racism play in that story?
Right. So I would say we have to think about scientific racism is not something that begins in 1619 and continues today, sort of unfinished. Like, it's just not this sort of uninterrupted process. Racial ideology as a way to explain the spread of infectious disease pops up at certain moments in certain places, not all the time. And this is a very nuanced sort of argument. So if you look at the British epidemiologists, Florence Nightingale, Gavin Milroy, are they racist? Sure. By certain metrics, you could say they're racist. Fine. Are they using race solely and fundamentally, exclusively, as a way to explain infectious disease? No. And Nightingale is measuring hospital rooms. She's trying to figure out ventilation. She's not just saying, oh, these are poor brown and black people, and that's why they're sick, period. She's invested in a large number of questions. She may, according to many metrics and many standards, be racist, but she's not using simple racial ideology as an explanation. Conversely, in the antebellum United States, you have people like Samuel Morton, who is measuring a skull and is measuring pulmonary capacity, and saying like, there is fundamental differences between the races, and this explains everything. So when the Sanitary Commission, which is an organization that grows out of the Civil War, similar to there's one that grows out of the Crimean War, when the Sanitary Commission grows up in the United States, they don't follow Nightingale's lead entirely in terms of measuring the rooms for proper ventilation, in terms of figuring out diet, in terms of washing hands, in terms of implementing sanitary conditions. Instead, they fall back on racial ideology. They end up saying, we need to conduct a survey, a physiological survey of the quote Negro. They talk about pulmonary capacity. They have doctors who, and I have this in the book, that are staring out at men, Black men who are bathing, and they're looking at their genitalia, they're looking at their bodies. They're saying there's something about their height. They're focused exclusively on racial ideology as a way to explain difference. And what's fascinating and also troubling to me, and some people don't get this argument because it's sort of nuanced, is that when epidemiology comes to the United States, it doesn't come with the idea that you have to see racial difference as an analytic, as what Barbara Fields calls racecraft. You don't have to see racecraft. And yet these people see racecraft, add racial ideology in, and then what they do, and I have this at the end of chapter 5 on the Sanitary Commission, they interview Southerners. They interview auctioneers of slaveholding houses. They're fascinated by mixed race people, and they want to know about miscegenation. They build an entire ideology around race, which is separate from the British. Now, again, I'm not saying the British are great. I'm not, sort of validating what they did or valorizing what they've done. I'm just saying that when you do a global history and you put these two sanitary commissions together, you can see that race forms much more prominently as an analytic, as a factor, than in the British. So that's
really interesting. So my last question, when I read the book, I couldn't help but think frequently about the medical experiments of the Nazis in concentration camps.
Yeah.
And I just wonder if you could say a few words about, continuities of the kind of research you described to the research that the Nazis undertook in the 1940s.
Right. So it's very similar. So first, you asked me that question when I presented at Harvard, and you're like, I think you need to do this. So I've been waiting 5 years to answer you, Sven. I'm waiting. I'm waiting. And
I forgot that I asked that.
No, because when it ended, you were like, no, I gave my answer then, and you were like, okay, yeah, I get it, but you're really going to have to have a thing about the Nazis. And so I was like having this, I was even talking to my editor, like, should I do it or not? Okay, so here's the thing. This very, very similar practice, and the argument is exactly the same, which is that the Nazis end up creating these controlled built environments that allow for medical experimentation on a dispossessed, subjugated population. It's incredibly similar. Now, this really just becomes a question of how you write the book. So I could have simply just tacked it on as an epilogue, but that didn't feel right. Now, if I were to go back to the drawing board, what I would have to do is expand the periodization to go up to germ theory in the 1890s and bacteriology and the rise of microbiology and how everything changes then. And then I would put on the piece about the Nazis in the early part of the 20th century. I couldn't go from the 1866 pandemic and then just jump over germ theory and bacteriology and get to the Nazis just because it looked the same. I would have to engage the ways in which, and my colleague and friend Jacob Steer-Williams is doing this, the way that bacteriologists were building on epidemiologists to understand the spread of infectious disease. So that would have been like 3 more chapters. And I really wanted to not do that, in part because lots of historians have done this. And I am, by calling and training, a historian really of the 19th century. Anne Douglas once said that, and I loved it. She was like, I am, by calling and training, a historian. So now I've just adopted that all the time.
But now that you took license to look at
yeah.
British history, maybe you want to move to the 20th century. Maybe this is the second volume.
Yeah, I think, it's interesting because I went to bed maybe about 2 weeks ago and I woke up in a cold sweat thinking about all of these records that I had from the British Library that are not in the book. And then I woke, I like had to get up and then look at my notes, and I realized a lot of them were from 1879 and 1882. So I thought, okay, I'm clear. But yes, I have volumes of materials that I haven't even looked at.
Yeah, no, that would be wonderful. I would love to read this book. So maybe, if you don't mind, Jim, we are going to open it up to the audience.
Right, sure.
And let me just read the first question here from Neil Pepper. Does your book consider the introduction of inoculation to Britain and America in the 18th century to be part of this chain of colonialism, enslavement, and capitalism as well? Or does the book really start with the mid-19th century epidemiology?
No, it starts there. It starts in the 70s. It starts at 1750. It starts with the slave trade, and also with this infamous crowded jail cell of British prisoners of war in India. And then the chapter on smallpox, which is another surprising, sort of unfortunate incident in US history, which is when a smallpox epidemic exploded among the Confederates and the Union Army during the Civil War. Both began the practice of purposely infecting enslaved infants and children to harvest the vaccine matter, the lymph, off of their bodies in order to create ways of sort of preventing the spread of smallpox. And in that chapter, I go back into, in order to frame that, I go back into earlier discussions of 17th century inoculation with Cotton Mather and others.
Right. Abigail Yanov, can you explain the modernity of bureaucracy? What does that mean?
Okay, so what happens is that really by the 1750s, what I begin to see is a real explosion in military and colonial bureaucracy. And the British are meticulous note keepers and meticulous record keepers. I mean, even to this day, their archives are just incredibly easy to navigate and to use. And so what I'm seeing is that the bureaucracy becomes a mechanism that's designed to capture the everyday, ordinary iterations of life and of capital and of the military campaigns and so forth. When disease outbreaks happened, say in London or in Philadelphia, you would have one doctor and they would be like, all right, let's try to figure this out. And maybe they could write to another nearby doctor, or there might be a few journals. I mean, I know some early modernists are going to argue with me on this, but like there's few places where they can actually find and collaborate with doctors. With the expansion of the transatlantic slave trade and with the expansion of the British Empire comes the creation of a magnificent bureaucracy that allows for doctors to begin to communicate much more regularly. So when cholera breaks out in Jamaica, Gavin Milroy can get notes from all other British physicians stationed throughout the British Caribbean. The bureaucracy has normalized the practice of record keeping, collecting information, and that then gives him, from the vantage point of an epidemiologist, the bird's eye view, what we would call the medical surveillance of a particular region. So colonialism creates a bureaucracy so that all of these various places can come under control of the crown, but ultimately it simultaneously sets up a network where doctors can watch and witness the spread of infectious disease.
So here's an interesting question by an unnamed attendee, and that is, since history often repeats itself, do you foresee this happening again in the future? If so, how can we prevent it?
I would say it's more, the question I would ask is, where are we getting our medical knowledge? Think about the pandemic. Think about how we're learning about the pandemic. Think about the question of when COVID-19 first broke out We understood it was an upper respiratory infection. We had general understanding of how it spread, a general idea of what it did to the body. How all of a sudden do we understand that part of the pathology then included the loss of taste, and the loss of the taste of smell and taste? Like you lost your, you didn't, how did this become something that we knew? This came from patients. This came from patients reporting to doctors, doctors understanding that in some way this mattered, and then they recorded it. So the idea is, the book is trying to say that medical knowledge is not simply the province of the elite, the scholars, but everyday patient narratives can help us understand larger medical questions and problems.
But to push you a little harder on that, I mean, you know, is it imaginable that conditions of confinement and coercion and violence would be used for these kinds of purposes again?
Well, yeah, I mean, but I would say it's different. I would just say, look at it this way. I mean, I would say it doesn't, think about the euphemism of essential workers. Think about the creation, think about how most brown and black people were infected by the pandemic as a result of the political economy. The fact that brown and black workers were living in public housing before the pandemic, in crowded, ill-kept environments, where they then became sort of canonized as essential workers, forced to leave their homes, forced to work with the public and grocery stores, forced to work in these places. And when they then they would contract COVID. And then all of a sudden, everyone understood it in terms of racial ideology. More Black people in New York are catching COVID. And there was an implication of, well, it's maybe has something to do with their appearance, without looking at political economy, without saying, actually, there is a social reason and an economic reason of why these people are infected, yet we've created this polish of this sort of essential worker that's not seeing how that has made these people vulnerable to the spread of infection. Think about today, even today, prisons. Long before COVID, high rates of tuberculosis among incarcerated people. Heather Thompson has written about this in the press a couple of years ago. HIV, other types of sexually transmitted infections. So prisons are a site where we see, as a result of the social conditions, high rates of infection. So, you know, COVID is really just magnifying already existing social ills and social problems.
What are the lessons for today?
I mean, this is, what are the lessons for today? I think part of it is, I think there's a couple, there's a lot of, I feel like on one, that question is like, on one level, I feel like I have to give some kind of like Pollyanna answer. I mean, here's a lesson for today. Here's a lesson for today. When we were at the height of the vaccination campaign and everything was going extraordinarily successful in the US, there were outbreaks of the Delta variant in Israel and other parts of the world. We were reporting on that, not simply just because we were getting information about what was going on in another part of the world, but rather that became a laboratory, that became a way to witness a variant of the epidemic. So we ought to pay attention, as early epidemiologists did, to how disease rates and infection rates are exploding in other places, not just as a matter of interest, but rather as a form of public health and control of an epidemic. And that we should also be thinking about this really, and I don't want to step too far off the ledge here in the present, but I would say there's a lot of discussion recently about boosters. Well, that raises lots of bioethical questions. If so many people in other parts of the world don't even have vaccinations, well, what's the point of a booster anyway? I mean, you know, the virus is going to continue to spread and explode in other parts of the world, whether or not you have a booster. The vaccination needs to get deployed there. So it's also checking our privilege when we talk about vaccination as well.
Right. And isn't it also the case, when we talk about COVID, that for a long time last year, many Asian countries were much more successful in containing the spread of COVID, but it's at the same level, they were not really considered to be in Europe or the United States. They were not considered to be experts in these matters. They were not necessarily consulted in how we should deal with the pandemic. Isn't there a strong of the kind hierarchies to describe in your book still present in the world today, that we can just not, in the West, we cannot entertain the thought that maybe we should be looking at Thailand in order to get a better sense of how we would deal with this public health.
Exactly. I think that's exactly right. I mean, I begin in the introduction, I quote a geographer, and I say that part of the reason why this information and medical knowledge never surfaced as canonical, or the origin as canonical, was largely because it took place in places outside the major urban centers. So you're right that, you know, the notion of expertise, you know, if we think about Thailand or we think about these other places, it's questioned, and we sort of continue to recenter the work of what's being done in France and other places. But if you think about smallpox, you know, this goes back to one of the earlier questions. The notion of arm-to-arm inoculation is introduced by an enslaved person in colonial Boston, which, you know, this practice of arm-to-arm inoculation, which I detail in my book, was prevalent throughout Africa and Asia. So in other words, we do need to sort of think about that. And in the end of the 19th century, or the middle part of the 19th century, there was the International Sanitary Commission that was sort of, at least objectively, trying to gather information about epidemic outbreaks throughout the world. And they would go into, you know, poor neighborhoods, and they would say disparaging things about those people. And I think historians today get too caught up in focusing on, oh, they said these disparaging things, without seeing that they were also trying to wrestle with a scientific conundrum. And so this idea of learning about science happened in these different places. I mean, bacteriology and the actual origin of cholera, the actual cholera bacillus, is discovered in Egypt. I mean, and then it's then the studies are then reproduced in the 19th century in India and within the water supply there as well. But again, because Coke is from Germany, it becomes a German story, instead of saying, wait a minute, indigenous people of that particular region became infected and died from cholera, which made the disease visible, which then made the theory visible. So if we are to think about what's happening in Thailand or Indonesia or any of these other places, we need to think about the fact that these populations are central to our understanding of knowledge.
Thank you so much, Jim. This was a really terrific conversation. And for all of those of you who are present who have not yet bought the book and read it, here it is. It looks beautiful. And as you just learned, it's also quite captivating and really very important. So I suggest that you go out and buy it right now. But thank you so much for having me. And it was wonderful to be part of this conversation.
Thank you so much for doing this, Sven. I really appreciate it. And thank you so much to Audrey and the Harvard Bookstore, and to Amanda Ice and everyone else who helped to organize this.
And thank you to both of you, Jim and Sven, for taking the time out of your very busy schedules to be here tonight and give us a fantastic conversation. And thank you to everyone in the audience who's tuning in tonight and showing up for authors, publishers, indie book selling, and our incredible staff at Harvard Bookstore. If you would like to purchase a copy of Maladies of Empire, which you absolutely should, check out the link in the chat. I posted them there. Please remember to shop indie and shop local, please, please, please. From all of us at Harvard Bookstore, have a great rest of your night. Have a fantastic week. Bye, everybody.
Thank you.
Bye.